Welcome to today's Explainer. So, you're prepping for your Certified Surgical Technologist exam, the CST. You probably already know this, but anatomy and physiology, it's not just some isolated section on the test, it's literally everywhere. It's baked into the procedures, patient positioning, instrumentation, and pathology. So today, consider this explainer your personal OR navigator. We're going to take that dry textbook anatomy and connect it straight to the surgical field. We're giving you a high-yield, surgically focused review that you can take right into exam day and honestly, into every single case you scrub. Here's the game plan. We've got 5 key stops on our map today: the surgical map, the pump and pipes, the airway and lungs, the control center, and finally, the structural framework. And I promise you, we're filtering every single physiological concept through a strict, no-nonsense surgical lens. Let's get to it.
Section 1. The surgical map. We are navigating cavities and quadrants.
Right off the bat, let's tackle an absolutely crucial distinction: peritoneal versus retroperitoneal organs. Peritoneal organs, think your stomach, liver, and spleen, are all wrapped up in the peritoneum. But your retroperitoneal organs, the kidneys, aorta, inferior vena cava, pancreas, and duodenum, they're tucked away behind it. Now, why does this actually matter? Well, it instantly dictates the surgeon's anatomical approach. If a surgeon is going in for, say, renal or aortic surgery, they're using a retroperitoneal approach to bypass the peritoneal cavity altogether. It completely changes the setup, you know? Now let's map this out into the 4 abdominal quadrants. You are absolutely going to see this on the board exam and obviously in the OR. Up in the right upper quadrant, we've got the liver and gallbladder. So think cholecystectomy or a Whipple procedure. Hop over to the left upper quadrant, that's the spleen and stomach, your territory for splenectomies and gastric surgeries. Down in the right lower quadrant, hello, appendix and cecum. That means appendectomies and the famous McBurney's point, which, quick reminder, is 1/3 the distance from the ASIS to the umbilicus. And finally, the left lower quadrant is home to the sigmoid colon, your main site for a sigmoid colectomy. Seriously, burn this map right into your memory.
All right, Section 2. The pump and pipes. Let's talk cardiovascular essentials.
Tracing blood flow through the heart can sometimes feel like trying to read a dense, confusing textbook paragraph, right? So we broke it down into a highly digestible, testable, step-by-step sequence. Here we go. Deoxygenated blood comes back from the body through the superior and inferior vena cava and dumps into the right atrium. From there, it drops through the tricuspid valve into the right ventricle, then gets squeezed out through the pulmonic valve over to the lungs to grab some oxygen. Okay, now it's oxygenated. It heads back via the pulmonary veins into the left atrium, passes through the mitral valve into that thick, muscular left ventricle, and boom, it's pushed out the aortic valve to the aorta and out to the rest of the body. You've got to know this sequence forwards and backwards.
Now here is a magic number you need to memorize: 60 millimeters of mercury. This is the absolute minimum mean arterial pressure, or MAP, required to actually perfuse organs. A normal MAP sits between 70 and 100. If that number drops below 60 while you're in the OR, you are looking at a literal intraoperative emergency because the patient's vital organs are just not getting the blood supply they need to survive. It's a huge red flag.
Speaking of blood supply, let's connect the major blood vessels directly to their surgical relevance. The aorta, the big one, bifurcates down at the L4 vertebrae. That is a massive landmark for AAA, or abdominal aortic aneurysm repairs. The inferior vena cava, it's a large vein that's actually at really high risk for compression when a patient is flipped into a prone position. Then there's the femoral artery, which is your main access point for cardiac caths and endovascular cases. Up in the neck, the carotid arteries are exactly where you'll be for a carotid endarterectomy. And we can't forget the saphenous vein. It's the longest vein in the body and is constantly harvested for CABG grafts.
Moving right along to Section 3, the airway and lungs. Time for respiratory landmarks.
Let's zoom in on the cricoid cartilage. This structure is super unique because it's the only complete ring of tracheal cartilage, and the surgical relevance here is absolutely huge, especially for a scrub student. In a crisis, like an emergency rapid sequence intubation or RSI, anesthesia might actually ask you to apply Selleck's maneuver. That literally means putting direct physical pressure right on this exact cartilage. Why? To compress the esophagus and stop the patient from aspirating stomach contents into their airway. It's a real game changer to know exactly where that is.
All right, let's test your spatial awareness of the lower airway with a classic high-yield board question. We know the trachea bifurcates at the carina into 2 main bronchi. So which main bronchus is the most common site for foreign body aspiration, or, say, an inadvertent endobronchial intubation? Think about it for a second.
Got your answer? It's the right main bronchus. And the reason is pure, simple anatomical geometry. The right bronchus is anatomically shorter, wider, and a lot more vertical than the left one. So if anything drops down that trachea, whether it's a swallowed tooth, a rogue peanut, or an endotracheal tube that gets pushed just a bit too far, it basically has a straight, easy shot right down into that right lung.
Section 4, the control center. Let's talk about the nervous system.
Okay, let's quickly contrast the two main divisions of the autonomic nervous system. You've got the sympathetic system, which is your classic fight-or-flight response. It uses epinephrine to jack up the heart rate, dilate pupils, and cause vasoconstriction. On the flip side, the parasympathetic system is all about rest and digest, using acetylcholine to bring that heart rate down. In the OR, anesthesia is constantly playing tug-of-war with these physiological swings. For instance, if a patient gets profoundly bradycardic because the parasympathetic system is taking over, anesthesia might push atropine to block those exact effects and wake that heart rate right back up.
Now, for the peripheral nervous system, you absolutely must know your 12 cranial nerves. Here's a classic, slightly cheeky mnemonic to help you lock them in right now. O to touch and feel very good velvet, heaven. That gives us olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. Just say that out loud a few times, and I promise you'll never forget the order.
But let's be strategic. Out of those 12, we're going to isolate the 3 most surgically relevant cranial nerves, the ones you are practically guaranteed to see on the exam. First, cranial nerve 7, the facial nerve. This one is highly at risk during parotid, mastoid, and acoustic neuroma surgeries. Then there's cranial nerve 10, the vagus nerve. This is a big one because its recurrent laryngeal branch is super vulnerable during a thyroidectomy. If a surgeon nicks that, the patient wakes up with severe hoarseness. And finally, cranial nerve 12, the hypoglossal nerve. This guy is at risk during a carotid endarterectomy, and an injury here will actually cause the patient's tongue to deviate to one side. Definitely know these 3.
Staying inside the central nervous system, let's talk about intracranial pressure, or ICP. A normal ICP is hovering between 5 and 15 millimeters of mercury. An elevated ICP, meaning anything over 20, is a massive medical emergency. The surgical team has to be lightning fast at recognizing the vital sign changes associated with this, which we call Cushing's triad. You're looking for 3 things: hypertension, bradycardia, and irregular respirations. If you see those 3 things happening at once during neurosurgery, herniation could literally be imminent.
And that brings us to Section 5, the structural framework, musculoskeletal landmarks.
I want you to lock these landmarks into your brain right now, because these are your absolute high-yield surgical bone landmarks. The sternum is your site for a median sternotomy, with the angle of Louis sitting perfectly right at the T4 level. The iliac crest, specifically the ASIS, is your go-to bone graft donor site. Plus, it's the landmark for McBurney's point. The greater trochanter of the femur, that requires some serious, aggressive padding when you've got a patient in lateral positioning. And lastly, the tibial tuberosity is the critical IO, or intraosseous access site during pediatric emergencies. Got 'em? Awesome. When we talk about joints, the knee is notoriously high yield. Think about the anterior cruciate ligament, the ACL. Mechanically, its whole job is to prevent the anterior displacement of the tibia. Basically, it stops the lower leg from sliding too far forward. Because of the massive stress placed on this exact mechanism, especially in sports, it's the most commonly torn ligament in the knee, which means arthroscopic reconstruction is going to be an incredibly frequent case on your OR board. Let's pivot to a highly applied clinical question that connects bone anatomy straight to a preventable nerve injury. Why does the surgical team have to carefully pad the lateral aspect of the knee when a patient is placed in lithotomy or lateral positioning? Think about the specific underlying anatomy there. Did you guess the fibula head? Because that's exactly it. The peroneal nerve wraps directly around this bony prominence. So in lateral or lithotomy positions, if the outside of that knee is pressing against a hard operating table or a stirrup without adequate padding, that nerve gets squished, and the result? The patient could wake up with drop foot. It's a devastating yet completely preventable positioning injury. Just to really hammer home this relationship between bony prominences and peripheral nerves, let's look at one more major positioning hazard, the medial epicondyle of the humerus. You probably know it better as your funny bone. Well, the ulnar nerve runs right along it and is at severe risk anytime there's elbow pressure. You've got to aggressively pad this area during lateral and prone positioning, or you risk giving the patient ulnar nerve neuropathy. Not fun.
Wow, we have covered a ton of ground today, turning standard textbook anatomy into a highly practical OR map. So, I want to leave you with this final provocative thought. Next time you're scrubbing into a case, ask yourself, how does this patient's specific position change the vulnerability of their underlying anatomy? Because anatomy isn't static, right? It's totally dynamic. If you apply these high-yield principles to every single real-world patient you encounter, you are not just going to pass your CST exam. You're going to be an outstanding surgical technologist. Thanks so much for joining me on this explainer, and keep learning.